Great. Welcome everyone to this, which is one of our Ethics and COVID-19 webinar series. My name is Paul Ndebele. I'm Assistant Director in the Office of Research Excellence in the School of Public Health here at the George Washington University, and I'm going to serve as the moderator for this webinar. Today, we are focusing on the Omicron variant and quarantine ethics. And these webinars are hosted by the Office of Research Excellence in the School of Public Health, and also in collaboration with our bioethics program in Bamako, Mali, with the University of Science, Techniques and Technologies of Bamako, and also with our research ethics capacity building program in Kinshasa, the Democratic Republic of the Congo. Welcome, everyone. To our students, I just wanted to announce that if you need professional enhancement credits, you can download the form from the public health website and submit. You are going to be provided with some instructions on how to proceed. So with regards to how we are going to proceed, we are going to have our two panelists giving their brief presentations, and then after their presentations, we'll then have a time for questions and answers. So I'd like to encourage you all to provide your questions and comments using the chat function. I'll be noting down the questions so that I can then pose them to our panelists once we get to that part of our webinar. So to get us moving, I would like to introduce our first panelist. So our first panelist is Dr. Renuga Vivekanandan, for short, Dr. Vive, who is currently the Assistant Professor of Internal Medicine and the Associate Program Director of Infectious Diseases Fellowship at Creighton University. Her research interests include health disparities, outcomes in organ transplants, antibiotic stewardships and outcomes, infectious diseases, quality improvement, and projects for better patient outcomes in clinical settings. Dr. Vive has received various awards, including the Master Clinician Award, the Best Doctors in America Award in 2015 and also 2016. So over to you, Dr. Vive, so that you can now provide your views on this very, very interesting topic.
Are you able to see my screen?
It's coming up.
Perfect. Perfect. Thank you so much for that kind introduction and opportunity to speak today about COVID-19. So, I wanted to kind of focus on Omicron and how it all started. So for the last 2 years, we have had a centralized process of monitoring different types of variants when they occur with COVID-19 globally. So all the sequencing, which are happening across the globe, is being put in a centralized process. And we're continuing to monitor if there's any variants that show up multiple times, if they're a cluster of cases. So on November 24th, Omicron was identified as a new variant. And November 26th, it was called as variant of concern because we started seeing clusters of cases. As you know, it started in South Africa, but it's across the globe now. And lots of different variants are occurring across the globe, but this was a variant of concern. So when it started, if you look in this graph, this was the initial graph in South Africa of how the different waves are occurring. And if you look at the red, the dark blue, and light blue waves, these were the first 3 waves in South Africa. The doubling time, which is infection in the epidemics in the community, how many infections are occurring. The prior waves were much longer when the cases doubled in the community, 1 to 5 days, 1 to 7 days. But with Omicron, what was really interesting was the doubling time was 1 to 2 days. Very infectious and is able to spread to others much faster and cause more infection rate in our community. So if you look here we are in United States. As of yesterday, January 24th, it's really nice to see it in this red line. This is an Omicron wave. It was taking a really big vertical infection rate, but thankfully we're seeing a downward trend, which is really positive. You know, I'm a frontline worker. I'm an infectious disease physician. I see patients. In our healthcare system, we have a lot of patients with COVID-19. So it gives me a little glimmer of hope. Maybe in the next 3 to 4 weeks, we might see a nice downward trend. As far as patients passing away, we're still, as of yesterday, over 862,000 individuals who have passed away from COVID-19 in United States. Globally, it's much larger number. And every day in US, more than 2,000 patients are passing away from Omicron variants. You know, I'm sure you guys all heard about Omicron is mild, the word M word. For me as a physician who is taking care of patients, it is mild if you're vaccinated and boosted, but for our patients who are not vaccinated, it's still very severe infection. They're, you know, being in the hospital and on the ventilator. So I think it really talks about the importance of vaccinating, and I'll get to that in a little bit. And this slide shows us the infection rate in our communities, blue being very low, red being very high. And if you can see across US, we are very, very high infection rate. And if you look at how many individuals have gotten vaccinated over the age of 5 and older. So as of right now, we only have a vaccine approved for 5 and older. At least 80% of that population has received at least 1 dose of vaccine. But what is really important to know is that we have to get fully vaccinated, and older, 12 and older, we got to have booster to kind of control this infection rate. So we're in a good place, but we have a lot of more work to do when it comes to having vaccination in our community. You get asked a lot of questions for me on a daily basis. Does vaccine work? Does boosters work? For adults who are unvaccinated, had 5 times higher risk of infection compared to adults who are fully vaccinated when it came to Omicron. So high rate of infection. But what is really positive is that Pfizer and Moderna, both vaccines with a booster dose, showed you have higher neutralizing antibody titers. Pfizer booster dose created 25-fold higher neutralizing antibody, and Moderna data also showed 20-fold higher neutralizing antibody. So not only a primary series, but booster is very important to help you fight against Omicron. But definitely getting vaccine is the key information. And, we get, again, Omicron gets compared to measles a lot because of the high infection rate. As you know, that was one of the big reasons. There's a really high advocacy right now and education right now for better masking to make sure you're containing your respiratory secretions well. I believe as of next week, we're going to have over 400 million N95 released to the community through the federal government. So higher quality mask is really important with Omicron. And if you look at this table here, Delta compared to Omicron, what happens if you're vaccinated versus not fully vaccinated in households? So with Omicron, if you're not vaccinated, almost 30% chance of household members getting the infection. Fully vaccinated, still 32%, and boosted, still 25%. And you could look at, compared to Delta, it was 19 and 11%. So clearly it's more infectious, and better masking is really important. But what is important takeaway message is that, yes, you might still get infection if you're vaccinated or boosted, but are you having serious infection? As an infectious disease physician, my main concern is keeping patients away from hospital and they're able to recover at home. So if you look at this graph, this light blue line is patients who are vaccinated and have received their booster vaccine. If you look at the dark blue line, who are fully vaccinated, have received their 2 doses. And this graph describes hospitalization by vaccination and boosting and non-vaccinated individual and the hospitalization rate. It's really amazing to see if you're boosted, your rate of hospitalization is extremely low. If you're vaccinated, it's still very low. But if you're unvaccinated, unfortunately, your hospitalization and having a severe infection is very high. 44% times higher in unvaccinated adults 50 to 64 years of age, and 49% higher in adults over the age of 65. So very high percent and risk of getting hospitalized if you're not vaccinated. So I know we're going to talk a little bit about isolation, quarantine. With that in mind, for isolation, current recommendations from CDC, if you're infected, if you're boosted, vaccinated, or unvaccinated, you should stay home for 5 days and wear a mask for a total of 10 days. But at 5 days, if your symptoms have improved and you don't have fevers and they're resolving, then you can leave your home. But you still have to wear a mask for a total of 10 days. At this point, for me, it's important you wear a mask at all times when you're in the community, but this is the current CDC guidelines. If you have the infection, if you have exposed, so you had a high exposure, so you didn't have a mask, close proximity with somebody for 10 to 15 minutes. If you're boosted, primary series, then you should wear a mask for 10 days again around others and get tested if possible at day 5. But if your vaccination has been greater than 6 months, not boosted or unvaccinated, stay home if you have a high risk exposure for at least 5 days. So the difference between quarantine is if you have had vaccination, then you just have to wear a mask and get tested. But if you're not vaccinated or if it's been a long time, then at minimum stay home for 5 days if possible. But if not possible, at least wear a good mask for 10 days to protect others around you if you develop the infection. So with that, I'm going to stop. That was the introduction of where we are. Thank you.
Thank you very much, Dr. Vive, for introducing this topic. You provided us with details on how Omicron came onto the scene. When we as society thought that the situation was improving, all of a sudden Omicron then came. You also provided us with the details regarding the admissions and deaths also related to the Omicron variant, and importantly touched on the similarities between Omicron variant and measles. But interestingly, you also touched on these 3 groups of persons. You spoke about the unvaccinated, you spoke about the fully vaccinated, and you also spoke about the boosted. right? So, and as we are aware right now, there are still discussions about changing the definition of the being fully vaccinated
Yes.
to move perhaps to those who are boosted.
Yes.
But we also touch then on the issue of quarantine for those who become infected and also those who become exposed. And of course, the criteria that makes the difference here is whether one has been vaccinated or not. So as we proceed with our webinar, we are going to touch importantly on some of the ethical issues around those decisions that were made by the CDC in coming up with those recommendations. So to get us moving, once again, I'm going to introduce our second panelist. Our second panelist is Mark Aulisio, who is the Susan Watson Professor and Chair of the Department of Bioethics at Case Western Reserve University. He's also Director of the Center for Biomedical Ethics at MetroHealth Medical Center. He is currently the Chair of the Council of Basic Science Chairs of the School of Medicine. He's also a member of the Human Studies Review Board for the U.S. Environmental Protection Agency. Mark has written widely. This includes book chapters and also articles around the bioethics in general and ethics consultation, organ donations. And recently, he served as a member of the COVID-19 task force of the Association of Bioethics Program Directors. And he was also one of the authors for the task force publication titled Ethical Challenges Arising in the COVID-19 Pandemic. So over to you, Mark.
Well, thank you very much. Very much appreciate the invitation to present, and tell me if you can see the slides. Are we good? Okay, thank you.
Yes.
So Dr. Vivekanandan, it's an honor to be on the panel with you. Dr. Ndebele, thank you for the invitation, and I really appreciate this opportunity. My background is really in analytic philosophy, and so I promise you that I won't take you down that road into the deep water, and we'll all drown, and not happily either. But what I've done in my career really from the mid-90s forward is clinical bioethics and on-the-ground issues, including issues surrounding public health ethics and concerns about quarantine. So what I want to do is a little bit of political philosophy, just a little. It won't taste too bad. Okay. I want to start with a caveat, and the caveat is that in the literature, folks will use quarantine and isolation a bit differently. Isolation is typically referring to somebody who has an infection, as Dr. V noted, and quarantine is about exposure. Now, I don't think we need to split hairs here, and I don't have many left to split, so I better not. We can just say, all right, we're talking about coercive measures from the state or other, well, primarily the state, but it could be other human associations, right? To limit folks' liberty in certain ways, right? And so this is inherently controversial, as we have seen. And what I want to do is surface for us the kinds of deep value considerations that should inform our public policy decisions, okay? So let's do a little bit of US government 101, because I think there's a woeful lack of literacy around this. What is our form of government? Strictly speaking, out of my political philosophy background, we say it's a liberal constitutional democracy. What does that mean? Well, in the United States, and there can be different forms of liberal constitutional democracy, and there are across the world, but in the United States, what this means is liberty, equality, and justice are embedded in our constitutional framework. It's also a federalist framework. There's issues of jurisdiction and authority, but people often talk about liberty as if it's the only value in our constitutional framework. This is not true. And the way I like to think about our framework is liberty, equality, and justice all matter. And liberty is primus inter pares, which is, if you pull out of the Catholic tradition, the Pope was considered the first among equals. The Pope is just a bishop, but also the Pope. So yes, usually liberty wins, but not always. But these are three fundamental value-laden considerations that are as more American than apple pie. Okay, all right. So what's the primary purpose of the Bill of Rights? In a nutshell, to protect the liberty interest of citizens from what? From who? The power of government and the tyranny of the majority. So think about, George III, kind of crazy guy, right? Drunk with power. But there's also risk from the tyranny of the majority. And so we all have, in a sense, this sphere of protections that the Bill of Rights give us against the authority of government and against the kinds of things that can be put to a vote vis-a-vis our own individual liberties, right? But our liberty interest unlimited, and in common political parlance today, one gets the impression that at least some significant percentage of the political spectrum thinks that liberty interests are unlimited. Well, not really, they're not, clearly. Now, you tell me, do we have limits on our liberty? The answer is yes, we do. Are liberty interests unlimited? Of course not. Here's one. School zone, 120 miles an hour. Well, wait a minute. What about my freedom? What about, well, there's a problem. Blitzing through a school zone at 120 is a problem. Why do we have school zone speed limits? Well, risk of what? Harm to others. The most fundamental liberty limiting principle in a free society, including ours, is the harm principle. And we need to reacquaint ourselves with the harm principle and our obligations to the broader society. Quarantine ethics and other social policy questions, mask mandates, vaccine allocation, vaccine mandates, involve other things, but also this. Respecting individual liberty, yes, but limiting it to the extent to which its exercise risks harm to other people and the broader society. Now, if we want to give this a bioethics tag, rather than just a political philosophy tag, we'll say autonomy and non-maleficence are things that we need to be dialed into as we think about quarantine ethics. Historically, public health mandates, you all know this. I mean, School of Public Health, bioethics, federal government has made mandates. State and local governments have made mandates. Public, private colleges, universities, healthcare organizations, other employers, there is no secret to mandates. By the way, on the liberty limiting principles, even a hard-nosed libertarian who thinks the only controlling value is liberty and wants to kind of sideline equality and justice would say, gee, you're not allowed to take your submachine gun out on your front porch and spray the sky with bullets. There is no right to do such a thing, never has been, and should, hopefully never will be. Anyway, limitations in light of the harm principle. History in public health, we usually push back in public health ethics. We point to Jacobson versus Massachusetts, right, where city of Cambridge mandates vaccination against smallpox. And Mr. Jacobson, Reverend Jacobson, actually a minister, had been exposed. Actually, he said he had smallpox when he was in Sweden. He was Swedish. I think I got it right. And he, the case made its way all the way up to the US Supreme Court. And I think it was Marshall Harlan, but here's the important part for us. I bolded it. Real liberty for all could not exist under the operation of a principle which recognizes the right of each individual person to use his own liberty, whether in respect of his person or property, regardless of the injury that may be done to others. Liberty is not unrestricted license to act in accord with one's own will. It's only freedom from restraint under conditions essential language a little bit purple here, to the equal enjoyment of the same right by others, right? So this is critical. The harm principle is paired with the police power of the state and the responsibility of the state to protect us from harm, right? If you don't have a harm principle limit on liberty, you have the mere exertion of power by the powerful, irrespective of consequence. You don't have a free society by definition. So the people beating the drum of liberty should be all in favor of public health protections when it comes to infectious disease. Big ironies here, right? Okay. Zoot versus King, another Supreme Court case. This was a case of a Rosalind Zoot, who was a teenager who in the city of San Antonio, who was being mandated the polio or the smallpox vaccine again. And I hope I said smallpox with Jacobson. If I didn't, that was a slip. Anyway, smallpox vaccine again. And her parents didn't think that she should have it. And they were even claiming some religious grounds. And the courts were really clear. No, harm principle matters. Police powers of the state matter. This is clear, and they cite Jacobson. Okay, and this is pretty invasive, right? A forced vaccination, a mandatory vaccination, right? Let's go to Prince. This case, Prince versus Massachusetts, involved I think an adopted niece or nephew, so a stepchild, whose stepmom was making her go out into the streets and promote Jehovah's Witness, and she was not over 18. And you needed to be over 18 as a female in those days to be working. All right. So this was considered in violation of the forced to the child labor laws. But here's the interesting thing for us about Prince. The court in its decision says, thus, they, right, cannot claim freedom from compulsory vaccination for the child more than for himself, theirselves, on religious grounds. The right to protect religion, to practice religion freely, does not include liberty to expose the community or the child to communicable diseases, or the latter to ill health or death. And you go, well, what does that have to do with promoting, Jehovah's Witness, passing out tracts? Well, it was citing, the courts are citing here, the parens patria responsibility of the state, and showing the various limits on liberty that even apply to religion when it comes here to protection of children. Isn't that interesting? But they go to the vaccine mandates, the cases that supported them. Jacobson, isn't that interesting? We've had them. This is not new. We still have them. It's not new. Okay, My Body, My Choice. Really fun, interesting read. Well, I don't know, fun maybe, but Dr. V has probably her own perspective on this. But Michael Rillich, Pox in American History. I mean, the things that were done, children were forcibly taken from families and sent to houses of pestilence, right? This happened. By the way, an interesting little political note. The first anti-vaxxers, as far as I can tell, in the United States were progressives. So strange bedfellows today, huh? And it was after the Jacobson case that progressive movement took up this banner, this anti-vaxxer banner. And now you have people who are beating the drum of liberty, who identify as conservative, endorsing this very progressive, historically, idea. I would say regressive, but whatever. Typhoid Mary quarantine, a real cautionary tale, an abuse of power by the state. What was it, 2 10 or 11-year periods out on an island? Poor Typhoid Mary during the typhoid outbreak, suspected initially because she was a dirty Irish woman, and we all know that I'm 50% celtic by my DNA analysis. So I think I can say this. You know, the view of the Irish was that they were dirty disease carriers. You weren't allowed to hire the Irish up and down the East Coast for a good stretch in American history. So, you know, she was suspected partly because, mainly initially because she was Irish. It turned out she was spreading typhus. It wasn't because she was Irish, it's because she was infected, right? And turned out to be a super spreader. But anyway, quarantine, big time, isolation, big time. When it comes to quarantine ethics, this is what should inform our consideration. Yes, liberty limited by harm. But if we go outside the United States, we want to highlight the Syracuse Principles, 1984, adopted by the UN. Here's a passage of importance from Syracuse. Any of these coercive public health measures should be legitimate, legal, necessary, non-discriminatory, and this I think is a screamer and important, represent the least restrictive means appropriate to the reasonable achievement of public health goals. The least restrictive means. So we're going to have to figure out, we're going to have a lot of empirical information, like Dr. V presented, to make a good decision about a coercive public health measure like quarantine, right? Now, in the literature, you're going to find some version of these four considerations, no matter who you read, right? Harm principle, we talked about it. Proportionality, least restrictive means to achieve the acceptable end. Reciprocity, if we expect people to be subject to coercive measures, we need to be sure that we take care of them, we compensate them. So part of the rationale for sending out, for example, payments to people is that we were asking people to engage in lockdown, right? You need to support those who are bearing a burden for the broader society, and that's a demand of reciprocity. And then transparency is, let's be clear about what we're doing, why we're doing it, and also allow an avenue for appeal. Okay, 3 questions to ask yourself when it comes to quarantine. Do public health and medical analyses warrant the imposition of large-scale quarantine? Oh, should have had a question mark there, sorry, I will fix that. Are the implementation and maintenance of large-scale quarantine feasible? Sometimes they're not feasible. And do the benefits outweigh the potential adverse consequences? Think about all the mental and behavioral health issues that we are identifying as a result of 2 years of pandemic, right? And some of lockdown, some of masking. Those things all matter too. They're hard to anticipate in advance, but that's what's on our shoulders if we're going to make good judgments for social policy purposes on this issue. Okay, thank you. And I will stop share.
Thank you very much, Mark, for taking us through Bioethics 101.
Yes.
So you explained, of course, quarantine and isolation as coercive measures, right? That coming from, in this particular case, the state. And you also discussed, the values of liberty, equality, and justice as important ones when we are thinking about limiting one's freedom through quarantine. But you also reminded us of the limits to our liberties. And of course, you took us through various court cases where it was actually decided, or it was agreed, that those restrictions were in order as a way of protecting the majority. And of course, you touched on the harm principle, which is very, very important in terms of limiting our abilities. You also touched on the principles that should inform decisions on public health measures, and of course, you asked the 3 very, very important questions, and I hope that the CDC was actually looking into those questions when they then came up with the recent recommendations around quarantine. So now, to get us moving, I'm going to pose a few questions And I'm also looking at our chat to see if there are any questions that are going to be coming in. But I want to direct this initial question to Dr. Vive. And this question relates to the differences in the quarantine expectations for the vaccinated and for the unvaccinated. So I would like you to comment on the differences between the quarantine expectations for the unvaccinated and for the fully vaccinated. Are we punishing the unvaccinated here? What are your views?
Yeah, that's a really good question. So with the quarantine, the suggestion of staying home at least if you're not vaccinated for 5 days versus when you're vaccinated, wear a mask for 10 days, but you could go out. The reason is we know that when you're vaccinated, or boosted, fully vaccinated, your chances of developing the infection is lower compared to when you're unvaccinated. The chances of developing the infection is much higher. So that is kind of the logic of, if you're unvaccinated, chances of developing and spreading to the community is much higher. So that, but also if you saw in that little CDC guidance, it also says if you're not able to stay at home, at least wear a mask for 10 days for quarantine. So ideally, it's really important to stay home so we don't, like the harm principle, we don't harm others if you develop the infection. But developing the infection in the unvaccinated is much higher compared to the other population.
Thanks, Mark. What's your comment?
Pardon, I couldn't quite hear.
What's your comment?
On this, I would say we have to be really careful to resist what has become, I think, a fairly pervasive urge to punish people for their behaviors through our social policy or our particular clinical care decisions. It's understandable that health professionals are frustrated by the numbers of unvaccinated and some of the rationale, and of course the criticism and even outright nastiness that they've had to endure, including threats. But in the end, we should not make public health decisions or clinical care decisions based on, whether we think people deserve X or deserve Y, right? We need to base it on the public health good and the most reasonable, plausible construal of medical best interest that comports with patient values when it comes to clinical care. We don't deny care to smokers. We don't deny care to people who, drive 120 in a school zone and then wrap their car around a pole, right? That's not the place for society to make those decisions about responsibility.
One thing that I could add is I really like the fact that we're going to be providing better masking. I think that will really help. Yes. Because if you are asymptomatic and if you are, having infectious particles, respiratory particles, giving everybody in the community good masking is going to be key to limit that spread as well.
Totally agree with that. And that actually, arguably, is a demand of reciprocity, right? If we're going to expect people to protect others from the spread of COVID-19, we have to give folks the means to do it. So there is a justification for making these masks widely available. We didn't have that early in the pandemic because we didn't have access to masks early in the pandemic. Not N95s anyway.
Thank you, Mark. I want to come back to you, particularly focusing on the shortening of the period for isolating or staying at home, right? So are we actually here thinking about issues related to whether someone is going to spread this infection to others, or now we are thinking more about economic reasons? So in coming up with that decision to shorten the period of staying at home. what were the issues that were taken into consideration?
Okay, so that is, I don't know for sure, right? Only the folks, say, in the room who made the policy would know. The best guess is that this was a combination of good data and considerations about other goods besides mere public health, right? And there's always a weighing and balancing, right? And I think there are trade-offs, right? So I think what we have in the shortening of the quarantine period for the vaccinated is data-driven, but it's also a concern about other public goods, right? Like a well-functioning economy. So I don't really know the answer, but that's my guess as to the considerations.
Thanks. And Dr. Vive?
I think it is both trying to control as much as you can from the infection spreading and the economy as well. So if somebody actually has COVID-19 infection, there's data, not for Omicron, but older data, at day 5, you could still be 30% contagious. At day 7, you could still be 10 to 15% still be contagious. So I think it's just weighing the benefit and the risk for the community. So that's why I can't emphasize when, our community members, when they have infection, they come out at day 5, the importance of wearing that mask until you're at day 10, so you're not spreading the infections to others. But there is a big risk of having infection even after day 5, spreading to others, but benefit versus the risk. So masking is really important.
Great. Thanks, Dr. Vive. I'm going to move on to a question that has been posed here by one of our participants, that's Erin. The question is, I have a question about how we try to protect those who are immunocompromised or cannot get the vaccine. Right, so we're looking here at 2 groups, those who are immunocompromised and those who cannot get the vaccine. How do we balance trying not to harm those who cannot get vaccinated and trying not to do harm to those who are vaccinated by requiring quarantine?
As far as the immunocompromised patients, I think we need to really keep them in forefront and making sure how we could help and not harm them. Because as you know, even if they're vaccinated, their antibodies, it doesn't respond well. A lot of the patients in our hospital, when they have chemotherapy, organ transplant, even if they're vaccinated, they still can get severe infection. So I think that's why, as a collective, all of us have to protect the most vulnerable. So we need to get vaccinated, do the right thing, so we don't spread infection to others who are immunocompromised. So, but thankfully, we do have some monoclonal antibodies I'm sure you heard about. We actually can provide that to some of our immunocompromised patients at this time, prophylactically, to protect them against for the next 6 months. Limited supply, but there's a little hope for our immunocompromised patients. As far as Mark, I'm going to pass this to you about not being able to vaccinate. For me, the question is, why are you not being able to vaccinate? What do you think, Mark?
Yeah, that's a critical question. And then you're going to have okay, so how should we limit the behavior of the vaccinated to protect what is going to be an extremely small percentage of the population that can't be vaccinated, if in fact that's the case? I think it's going to be more about local, right, in the vicinity, the people who are engaging with and interacting with those who can't be vaccinated, rather than writ large social policy. I don't think you can do, just as hard cases make bad law, outliers don't make good public health policy either. It doesn't mean the outlier is not relevant and that we should disregard the outlier or the unusual case. It means that we should accommodate it at the level at which it presents itself. So I think addressing it closer to the ground, more locally, in particular populations is the way to go there, rather than broad social policy.
Right, there is another question here directed to Dr. Vive. How do previously infected individuals that have not been vaccinated fare regarding the rate of hospitalization?
Yeah, that's a really good question. And there's now data to support this as well. If you have an infection with certain variant, you might have some immunity for up to 90 days, but then it kind of falls off, especially after 30 to 60 days. So unfortunately, if you had alpha variant infection, it's really not protective for Delta. We have seen many patients with previous infection currently getting hospitalized for the newer variant. But what we do know is vaccines are able to protect against all the different variants. So previous infection, unfortunately, is not the best immunity because it tends to wane off.
Thank you. Mark?
Well, Dr. Vivekanandan certainly is the expert on that. I did see, was it last week or the week before, some data came out, I think pre-publication, on it sounds like the best thing overall is that you were vaxxed, you were boosted, and you got Omicron and survived it.
Yeah. Well, it's not interesting that you mention it because we had a big journal discussion regarding that study. There's a lot of biases in that study.
Interesting.
Yes. And they left out a lot of important concepts in there. So I still would suggest, getting different variants is not the best. Getting vaccinated is the most important information, thing to do for your immunity. It's okay if you have previous infection. Unfortunately, what we are learning is different variants, it gives you protection for that variant, but unfortunately, natural immunity doesn't protect against the newer variant.
That raises a really important question that has emerged during COVID, and probably it happened in 1918 as well, I suppose. But that is the way we are influenced by our broader political views when we interpret our own data as scientists. I mean, we knew unconscious biases invade in many ways, and this could be another. Yes, I'm politically, I lean in this direction, but does it shade my interpretation of what's supposed to be value-free, even though it's not, empirical data? I think we all need to check ourselves and be real careful on that.
Right. So here there is another question about looking at, for example, China and Australia as zero COVID examples, right? And then we look on the other hand at the US and Tanzania as countries that do not have an explicit goal of reducing community transmission. So here looking at two opposites, right? So can you comment on these countries in the context of your framework? So I can start off with Mark.
Right. So the zero COVID ship sailed a long time ago for the United States. It especially sailed even with contact tracing because we didn't dial in right away and implement our pandemic manual that we had. And that, whether people think we should have implemented it or not, the failure to implement certainly left us in a really bad spot in terms of limiting the spread of COVID in the population. Do I think the goal of zero COVID right now is realistic at all? No. And I'm not convinced that the sacrifice of individual liberties is warranted to achieve a zero COVID goal. So the degree of sacrifice, the degree of restrictiveness. On the other hand, it was handled pretty well. And, you know, Australia did well early. New Zealand did well early. And I think if you get to this problem early, you can have less restrictive interventions, less coercive interventions, and achieve maybe not zero, but really limited spread. And that's the sweet spot, I think. But, you know, we missed the sweet spot in Europe and in the United States, well, pretty much everywhere except for a handful of places. So, Dr. V?
Dr. Aulisio, yeah, I completely agree. I don't think zero COVID is possible at this time, but having good public health policies and vaccinations would be helpful. But what I predict is that we're going to have more surges. You know, this is just, you know, we're going to continue to have these for another 1 to 2 years, but we just need to make sure we have the tools, good masking and, you know, things like that. But we really have to get vaccination. So what I think as an infectious disease physician is this virus is here to stay, but how mild do we make it? And in order to get it milder and not hospitalization is going to be vaccination being the key. You know, even with Omicron, when we look at the data, the people who are vaccinated and boosted are not getting hospitalized versus the rest. So how do we get public messaging and trust and get rest of our population vaccinated is going to be really important. And this virus then will be in our community, but not as severe in the future.
Thank you, Dr. Vive. I want to come back to you, Dr. Vive. You mentioned some flexibilities about the current CDC guidance. Mm-hmm. You mentioned that the guidelines actually state that if you are not able to stay, right, then you need to be wearing masks for 10 days. Can you comment on that flexibility?
Yeah, I think, you know, just because we have a policy like you should quarantine for 10 days, I don't think we could enforce that. I don't think a lot of people are doing that, unfortunately. So at least giving the tool of if you cannot, because, you know, there are also to remember, like, you know, there might be somebody has to go get groceries, has to do other things that are vital to their household. So just making sure that they still have that flexibility with masking. So the masking is to make sure you're source controlling, so you're not spreading it to others. I think that's where CDC is giving that option. If you're not able to stay, at least make sure you're able to wear a mask so you could go, when you go into the community, you're protecting others.
Mark,
I really don't have anything to add on that. I completely agree.
Thank you. One of my last questions now is to do with the current changes. There are discussions in other countries about lifting all these restrictions, right? So it looks like the Omicron variant has actually been a game changer. Can you comment on the implications of the Omicron variant when we're looking generally at the prevention efforts that we're engaging in as a society? Dr. Vive?
When we lift all the measures we have to be prepared to deal with the consequences, hospital capacity, healthcare capacity. So I think it's really important to assess in each country what are they capable of doing. Right now, for example, in US, like where I am in Omaha, Nebraska, we don't have a mask mandate and things like that, and our infection rate is really high. So the hospitals and the healthcare workers it's been really difficult. So I think it has to be a balance. What can you do in your country? How can you make sure when you have severe cases, treat the patients who need the healthcare? And how can you take care of other patients in your community with other health issues? So I think that there's a bigger picture weighing all those important topics.
Thank you, Mark. Yeah, I definitely agree with that. I suspect that we are moving toward endemic, and overall, I think it's a good thing. The optimist in me thinks that Omicron might have been a little bit of a break for us because it might get us faster to endemic, but that remains to be seen because there's been a lot of damage with Omicron, as we've seen. Our hospitals in Northeast Ohio followed the kind of New York, New Jersey spike with Omicron. We're now going down, but we had easily the worst stretch since the start of the pandemic here in Northeast Ohio in the last month. It was awful, and it's still pretty bad, but the numbers are now going in the right direction. And our healthcare systems were, basically without open beds for weeks. And we have a high percentage of ICU beds per population relative to the rest of the country. I mean, because we've got the clinic and Metro, the Louis B. Stokes VA, and university hospitals all these in a very close proximity. So I'm hopeful that we're moving to endemic, but I don't think we're going to be done with coronavirus for a while unless we get the magic bullet from Pfizer or Moderna and they get the sine qua non, the identifiable feature of coronavirus that every coronavirus must have to be coronavirus, and we can target it and knock it out without doing a bunch of other damage. So we'll see.
Thank you, Mark. I'm going to give Dr. Vive 1 minute for your parting shots.
Yeah, well, thank you for this really good discussion. I think COVID has taught us a lot. I think we are, as a community, very resilient. The healthcare community is really resilient. Frontline workers are really resilient. I really think, I always say it's not about I with COVID-19, it's about we and how do we work together to help each other to get through this. And I also picture in the next year or two, we're still going to continue to have these waves. So I think how can we know some of the tools that work really well, wearing a good mask, washing your hands, staying home when you're ill. And I think we all need to continue to do that. And anything we can do to promote vaccines is going to be really important. So thank you.
Thank you very much. Mark, 30 seconds.
So I would second what Dr. V said. I'll paraphrase Bono. There is no them, only us. I think the fundamental challenge for us today, for our age, is to overcome in-group allegiance and out-group hatred. If we can't do that, we can't meet the demands of the pandemic, nor can we meet the existential threats we face. Last thing is liberty without a harm principle limit really is tyranny.
Thank you very much, Mark. I wish we could actually have that on our newspaper, headlines. Having liberty without thinking about harm to others would be the worst thing that we can actually have as a society. So thank you very much to our two panelists for taking your time to share your views on this very, very interesting topic. And thanks to everyone for joining us today for this interesting and yet challenging topic. So we look forward to seeing you again during our next webinar. Thank you and goodbye.
Thank you.